Well, maybe before we start the fireside chat and continue collectively, let's give a big round to Dr. Charlie Brule, Dr. Andrew Landstrom, and Bryn. That was great this I just came up from the teenagers chat, the private chat, and I can only say you have amazing kids. So I won't tell you which children asked about which, or young men and women asked about which, especially which one asked about getting drunk, so that you can just leave it to wonder which one of you has to be most concerned about alcohol. But they had great questions, and Madison and is it Kian? Cian. That's a great name. I love that. And Cooper and all of them. Reese and Reese's sister. So just great kids with great questions. They're really listening in the office. So always be aware that they pay better attention than what you might give them credit for. So I think we're open to anything and everything. The way we do this is. Just like with the kids session, there's no question that's unacceptable. So we just get a chat. You get a chat, I think, till 12:15 with them. You'll see me leave right at noon, because I guess if you're 2 minutes late, then Uber starts charging you or something. But I did practice how to get to the Uber pickup spot. So I did a dress rehearsal, so I can run it right up to the edge of time. So anything you want.
We talked a little bit about devices before. Would you guys be comfortable talking about on the retail devices like iWatches and other commercial products to monitor heart rates and ECG, and how useful or not useful you think they might be?
Yeah, like you're suggesting, there's a lot of movement and technology for home monitoring, heart rate, rhythm, those kinds of things, and they're getting better. The one caution is several of those devices may be made for adults, and so you want to make sure that what you're using is something that's a reliable, vetted thing, and I'd encourage you to talk to your physician about the specific one. They can, many of them do a very good job at capturing your heart rate. Some of them, like the Apple Watch, can give you the ability to capture your ECG. I think it's version 5 and beyond, or 6 and beyond, or something like that, and send it to us. So, but that's all they do, is really capture the rhythm, and then it allows you to transmit it and then engage your physician to talk about what it found. But yeah, there's a lot of movement, and they continue to get better.
So I'm conflicted. So Mayo Clinic and I have a relationship with AliveCor. So they're a company that has produced the device CardioMobile. That device is the one you see on commercials you put your fingers on, and the newest generation you put your fingers on and then on your knee. That's the 6L. That's FDA, that one. Yeah, that's FDA approved for a long time for a rhythm that we don't talk about here called atrial fibrillation. What we've done is we've created the artificial intelligence QT detector to add to it, and that got FDA cleared in April. So it's the first time we've had that, but it's cleared by a prescription, which is really cumbersome right now. So you can't put it on and see your QTC readout. Now you can put it on and get the trace and send to us for us to take a look at, but the next step is to try to convince the FDA that you don't need a prescription for them to turn on the QT feature. And I think where that's going to have a role, not even so much in patients with long QT syndrome, but you can think about all the settings in psychiatry where the psychiatrists are prescribing medications with a QT signal, methadone clinics that do QT monitoring or could do QT monitoring to see if you're actually taking your methadone. So there's going to be a lot of applications for it. But for our long QT patients, you could check yourself if you're under the weather with vomiting and diarrheal illnesses and say if your QT is lengthening, maybe you better be getting your potassium checked. So there's going to be some ability to monitor your QTC, and I think right now it's in that awkward requirement of a physician prescription to get that feature turned on.
See that expanding to other measurements like QRS duration?
No, well, I don't. I don't know if they are in the works for using it to make those kind of measurements. It's just the so-called deep neural network QTC detector is the feature that got approved. Yeah.
So I don't have any relationships like Dr. Ackerman, and for those of you that have worked with me, it really depends on your child and your disease or your and also what's going to work for your particular family. So for example, I use CardioMobile. It depends if you're having some symptoms. I've used it in a Tango 2 child because QTC is concerning. Now, we didn't have this feature, but we used it in a different way. I think that in particular, our goal is to make sure that your child has as normal life as possible. If that device helps, then perhaps, for example, if it makes them feel better, if they can, they feel safer, for example, if they're jogging or if they're running to keep their heart rate under something, maybe we'll use it. But if that makes them anxious, because every time they're going to use that and that's going to make them anxious, that's not the right person to use it. So it really needs to be tailored to your specific child and make sure that they understand that they're not getting more anxious because they're using this device. So again, it's hard to say that there's one thing that we use for all of you. We might not use anything, but work with your own physician and figure out what works for your child and your specific disease. We have certain monitors, for example, Dr. Brule showed you the Link monitor, where we really need to track you. And if that's something we need to do, then that's something we might have already talked to you about. But that's the one that really gives us everything. It really monitors you much more closely. If you have a device, we're already doing that because it's monitoring you. So again, it's tailored to each family.
Yeah, and I think
I've actually. Oh,
go ahead. I was just going to say that Dr. Miyake brings up a great point. You know, the purpose of why you're having it on. I have several patients that have either a watch or a monitor, and it makes them more nervous. And so, you know, you get calls about they're at school and their heart rate got a little bit fast. And so for some kids, it just adds to anxiety. And so I think the purpose of why we're having it on is an important discussion.
Yeah. Without a doubt, I've told more of the patients to get rid of their monitoring watch than to go get one. So, which means, except for what I think is going to be a bit of a change with QT monitoring in certain diseases and actually not even long QT syndrome, I don't need to give my well-treated patients a heart rate limit. So many ask, what's the heart rate that I can't go above? And I'll say, oh, how about 250? Because I don't want them thinking that they're somehow tethered to a heart rate. And so there's part of that anxiety thing that's very, very real. And
I also think you as the parents know your children better than we do. And so you'll see that, when you work with us a little bit longer, we get to know your children too, but you play a really important part in helping us figure out what's right for your child because nobody knows them like you do. Or if you're an adult too, you know yourself.
Total different subject, but more CPVT specific on the LCSD procedures and just how have they been, I guess, better outcomes? Are we seeing better outcomes with that procedure as it's been done more and more often? And when is it being recommended to be done? Is it becoming more of a common part of the treatment plan, or is it still reserved for people that are having more breakthrough? Just looking down the future with my daughter.
Yeah,
and
so great question. I'll start with it. We do more denervations than anywhere in the world. It was first done in 1974, so it's not a new thing. What became a new thing for the procedure is converting it to a minimally invasive with the video cameras and the video scope, so making it endoscopic or videoscopic, if you will. It used to, so you can see the evolution of it. It originally was reserved for, I have really, really bad disease. The treatments aren't working. My defibrillator's firing. Can we make that less likely? Not zero, less likely. So anybody who says denervation is a curative surgery is wrong, because that's not what the truth is. But it started with that group of patients, and that's where we saw, and Peter Schwartz revealed the strength of the signal in 2004. So we know it's therapeutic efficacy for a long time now, almost 20 years with good signal. And then over time, it shifted. So right now, I have two groups of patients basically who come for denervation for long QT or CPVT. There's no role for it for Brugada, for example. So I met one Brugada family from the teenagers. So only long QT, only CPVT. There's some use in a different disease, but is really twofold. Bad disease, treatment's not working, stop my defibrillator from shocking if we can. And then the newer group over the last 20 years has been not bad disease, but thank you very little, I hate life on therapy. So not bad disease, but bad beta blocker experience. So wanting and seeking a better quality of life. And right now in our program at Mayo, it's the half and half. 50% are bad disease. 50% have concluded that feeling the way they feel on their current medication therapy is not acceptable. And so they're seeking a way to feel better. So the efficacy signal is absolutely the best in type 1 long QT, next best and really close second in CPVT, third in LQT2, and then the others start to drop off where it's not that good from my vantage point in bad LQT3. And so we won't be quick to offer that one necessarily for somebody with tough to control LQT3.
And I have heard a little bit about the side effects of the procedure. Is that something that's better managed now, or that
Yeah, I think the side effects, it's a really important one, and to get it right, because what kind of happens in the Facebook world, I suppose, is somebody who's had a bad denervation side effect, or what they've concluded bad, gets amplified in an echo chamber, and it seems, oh my goodness, this is terrible. So I'll set the record straight. The guaranteed sequelae of the denervation is the left hand is drier and warmer than the right hand. That's guaranteed. Has no effect on dexterity, tactile strength, anything. And that's just because the real estate that comes out, the sweat fibers come out with the territory. So that's basically 100%. The look, which is this look where the left side is pale and dry and the right side is shimmering in sweat and red, is called the Harlequin appearance. It's of no consequence. The only consequence is if you didn't tell them and they came in from a workout and looked in the mirror and, so I had one of my denervated patients, she sent me Two-Face for her Halloween character. So she's a marathon runner who thought she'd be clever with the look. So none of them have really ever said, that look, if I would have known about that look, I wouldn't have done that. The 3 to 5%er is the droopy left eyelid. And by droopy left eyelid, it generally, if you are that 3 to 5%, you join the 10% of the planet that has a natural droop anyway. So we've done one eyelid lift surgery in our first 400 surgeries. So it's almost never of consequence. So that's a 5%er. The one that gives pause from being too, I would say, let's denervate the world, is post-denervation neuropathic pain. So when you cut those nerve endings and that you leave the raw endings behind, in some people, they feel the pain, feel neuropathic pain or nerve ending pain. That signal of some people is solidly about 5 to 10%. It goes away in everybody. Everybody has a residual pressure point spot. It's about the size of a nickel, where you say, don't give me a shiatsu massage right there. But nobody cares about that. Those who show up with the pain, it's about 2 weeks later that it arrives, and it's in here and in the left arm. And again, in that group, it goes away. But what we're seeing is that 5 to 10% is overwhelmingly occupied by those who dealt with a variety of pain sensitization things throughout their life. So if they have chronic fatigue, fibromyalgia, everything hurts, they'll be the ones calling us 2 weeks later to tell us they got the pain. And then those are the ones, that combination also is a combination that expresses themselves in. So I think the pain thing has gotten an echo chamber bad rap. I mean, for those who get it, it's not good. and we need to figure out some solutions, but it's not scary. And so we've published a quality of life paper, and the bottom line was everything I just described, the parents and the kids, whether it was a kid who had it or an adult who had it, 95% I would do that surgery all over again. And that's really high satisfaction for the beta blocker. I hate beta blocker. For a semi-elective surgery, that's pretty good. But that's the list of the trade-off. So what's the upside, what's the downside? That's the summary. And each of them I know Bryn has sent patients from Michigan, and Andrew has, and Dr. Canner has, and Texas Children's has as well. And you might, if you've seen any other things that I haven't summarized there, but that's, and thanks for giving the time to talk, because that's a key component of the treatment, armamentarium that we have that a lot of places don't have. And that's one of the challenges, and I think that's what I loved about Bryn's talk, is getting connected. So Dr. Canner's a great NEP. If he doesn't have that at his program, he can get on the phone and say, let me get my patient to you, type thing. And I think sometimes in the EP world, every EP program everywhere can throw in a defibrillator. So when you can throw in something, you throw it in. If you don't have it at your center to offer, there's a tendency to downplay it and say, well, I don't know if we really need that treatment option. And you need to have the right kind of physician who would be able to say, we don't quite have a treatment that I think would be great for you. Let's get connected with another member of your team, and we'll do a tag team. And I think that's a real important point that, Bryn, in your talk you brought up.
Mm-hmm. And I think it points to, making sure that you go somewhere where there's that expertise, because when you talk about those echo chambers, you could be not aggressive enough and really try to avoid, the side effects, but not have an effective sympathectomy, or you could be very aggressive. So connecting with places that have good experience and do it. You're in a good spot. Yeah.
I concur.
I don't have much to add. I mean, I think, Dr. Ackerman really kind of summarized. I think one of the things we typically, just in general, we don't usually do this in really young children. So if they're not if they're not in the high risk category, although, things are changing. I think that's what's so important, is having expertise and having someone who does so much, and kind of things evolve over time. So right now it's not our mainstay if you've got a completely asymptomatic child who's well controlled, but it's hard to know. Things are coming. We're doing all kinds of, and I'll talk about some of the research studies, and that's where it goes. And we hear from you guys, what are the side effects? How is quality of life? Mm-hmm. Do we need to think about this?
There's this mantra in medicine now, in precision medicine, right drug, right patient given at the right time. And I think it's really now should be expanded to the right therapy given to the right patient at the right time. And so we, in fact, have over 100 patients with long QT where their treatment program is one-time treatment called one-time denervation, no daily medicine, no nothing else. And again, that's not the every patient, that's the right patient. That certainly would not be a dangerous, spooky, high-risk patient who has a very twitchy substrate. But that might be somebody who has said, you know what, I'm not going to live this way, the way I feel. So we get, so beta blockers also get a bad rap, right? Because the bad rap comes from programs like ours, where if they said I went there to get a denervation because I was the beta blocker zombie, which I didn't invent the term, you all gave me the term, or those of you, including patient from two days ago, he offered up, I'm a zombie. So we have an ascertainment bias at our program, meaning they've already concluded they're a zombie, they've already concluded they don't like life on beta blocker, and they want to seek alternatives. That doesn't mean everybody's a zombie. In fact, most patients, tolerate their beta blocker beautifully and acceptably. And so if you're doing good and you're satisfied, why would you engage a surgeon? So I always say, keep the surgeon in the bullpen, because surgery's never free. And so you have to weigh the trade. Am I content with quality of life on my beta blocker? And if the answer is yes, great. If the answer is no, explore with your healthcare team what the options might be.
Hello, everybody. My name is Matt Lambert. I scared your mom. And I've been diagnosed with prolonged QT for most of my life. Yeah, and just to kind of back up what Dr. Ackerman said, I came and got genetic testing from him 10 years ago in Rochester. And since the age of 12, I was on beta blockers, and it really actually saved my life because I was passing out all over the time. It was scaring me, and I didn't think I would live past 30. And so I went to meet him in Minnesota, and he put me on a stress test, and I was on the stress test, and my heartbeat went up to something like 104, on 12 minutes at the stress test. And he said, "How many beta blockers are you on?" And I think I said something like 120 milligrams of beta blockers at the age of 40 years old. And he said, "How much do you weigh?" And I said 180 pounds or whatever. And apparently I was on 3 times the amount of beta blockers that should have been on since I was 12 years old. And he said, "Do you ever feel sleepy or dopey or tired or whatever?" I said, "I don't know. You've just been describing my life the last 25 years, so I'm not really exactly sure how to answer that question." But he reduced my beta blocker, and the world started moving a lot quicker for me. So I had to get used to that. But I'm still, even 10 years after, interested with the denervation surgery, and it's something that I'd be considering, since I've got about 30 years left on this planet, and I want to kind of see what that looks like. So thank you very much, and God bless you guys for all the work that you're doing up there. This is my mom.
I have a lot to say, but consider me a thank you card full of cobwebs, because Matt is 53 years old now, and his fainting, quote, quote, started when he was 3. And my compliments to all of you gentlemen, scientists, parents who have lived through this wilderness, as I called it, because when in 1973 there wasn't one soul who knew anything about the term QT. And to hear what you all are talking about today is like some kind of miracle just burst out of the sky, because I'm still talking about it everywhere, but I can't tell you what I feel that your strides have been, and along with Dr. Ackerman and Dr. Vincent and all the other gentlemen, who just to hear what you're talking about is like, what an amazing accomplishment you have made and changed so many lives. And I'm a blabbermouth to contend with, but yesterday on the plane, the lady sitting next to me was reading a book I was interested in, and we started talking, and I told her where I was coming, and she pulled over her blouse, and she had 3 big scars from stents, and she told me what she had behind her breastbone or something, and they couldn't find, I can't remember what the name was, but she was sitting alive next to me. My son is sitting alive next to me, and thank you all for continuing it. And God bless you. And heaven only knows what the future will hold. And lots of health to all of you and a good mind to keep smiling through it all. And thanks, Dr. Ackerman in particular, and Dr.
Nora.
Vincent, of course. Thank you all for letting me speak. Okay.
Okay, we're just getting warmed up, so these are amazing questions. Thank you, Nora.
You gave me tears in my eyes. My son is a patient of the wonderful Dr. Miyake, and we just had an appointment recently, and Dr. Miyake told us to come to this, and she wanted us to ask you a question in the Fireside chat. So,
It's a setup.
It's a setup.
no,
She's testing me, but I have to interject before you ask. I like that, the wonderful Dr. Miyake. I think that's a movie. I think we should make a movie.
There you go.
The wonderful Dr. I like the way that
Who
sounds.
did I tell you to come talk to? The expert.
But she definitely wanted to kind of, because we're in the variant of unknown significance, that kind of gray area.
Yeah.
And my husband's dad died of a sudden something when he was 34. So then when my son started having problems, we just assumed when we did the genetic test, because he tested positive, it was going to come from that side of the family. Well, it didn't come from that side of the family. It came from my side of the family. So I also have the same genetic mutation. Yes, thank you. But I've never had, like on stress tests and all that, the same that he has had. So it's interesting because I've learned how important genetics are, and I don't know my birth dad. So I've been on a quest. It's been very interesting. I've found some very positive people on that side of my family who have been very open, and some very negative people. Turns out I do have a half-sister who does have some type of a heart condition and does wear a device. She's not told me very much information. She's not very forthcoming, but I don't believe, according to her, it's long QT. It's something else. But since we are in that kind of mixed variant, Dr. Miyake wanted us to kind of talk to you about, because, he doesn't need a device, thank God, or anything like that. But we've been on medicine, and he doesn't like taking medicine. Of course, I like him being on medicine because it makes me feel comfortable, and just kind of the research on, I don't even know what the, I have it here. What did
You're off, though, right?
What is
Off
it?
medicine.
Right, but I don't know what the mutation is.
No. I think this is a good point, and many of you probably don't, and so I'll kind of fill in, don't have to deal with this because hopefully, your variants are known, or what Andrew talked about are pathogenic, so they're known disease-causing variants or mutations, and although it's not, no one wants to have a disease, at least you have that diagnosis. There are families and individuals that deal with this unknown, this uncertainty. Do I have it or do I not have it? And so that's kind of what they're being open about this. They have a variant, and you can see that this, she's talking about her whole family history and trying to get the details so that their physician can make a better assessment. Is this real or is this not? And it's very hard if you don't have all the details and you have somebody who might have heart disease who doesn't. But we take all of this into consideration. Now, if you're and over time, we might put you on a beta blocker early because we're not sure. So this was earlier on, but I think now the data, and I think this is a lot due to Dr. Ackerman, so I wanted, to assure that if your QT is not that long, we don't have any definitive evidence that you have disease.
Right.
Then you don't necessarily need to be on a medication. And that hard part is taking it away, that safety. And I think that's where they're at.
Yeah.
And we have taken it off, and he does not meet your criteria. He's kind of always been on that border. I don't know if you want me to tell how much you want, but on the borderline. And so and Dr. Ackerman has specific criteria, and he does not meet that now. That's why we took it off. And
I think the general is there are cases where everything is straightforward, right? We know which page book to turn to, and we know now, like Nora was saying, compared to 50 years ago, we now know exactly how to read from that page. and then it's a matter of executing the game plan. And the future game plan is getting added, and the future is really exciting. The timetable's not going to be as fast as what you want, so we need a bit of a reality check as to when gene therapy is going to arrive, if it works, and I can give you a sense of that if we have time. But I think in cases like yours, where the story's not hanging together to your satisfaction and to Dr. Miyake's satisfaction, what you need is I would say, a tenacious pit bull-like detective who just sinks their teeth into the information and says, I'm not satisfied. So I always start back at first principles and say, do I even think said person has a disease? And I forget about the genetics. And if I'm not seeing disease, I'm not treating. And then I work to say, okay, what was that thing? Because I was expecting it from that side, but now it's on this side. Now I have to make a rendering. And the companies say it's uncertain, but we need to be forced to say, they called it uncertain, yep, we're stuck. Or no, they called it uncertain, I'm calling it benign, and let's move on. Or they called it uncertain, and like that, I elevated it to pathogenic because I know stuff that the genetic test company doesn't know, like who am I seeing? So you have to make some commitments and then execute the plan as best you can, and then reassess. And I think that's an area, like for example, if you're a sudden cardiac arrest survivor and you don't have a name of your condition yet, what we see all the time is that the adult person who implanted it being the box, they're kind of done. The detective work ends. You had your cardiac arrest, you got your defibrillator, the search for the answer is over. And I say hogwash to that. So our approach is, yes, you might have gotten your device, but we ought to keep on trying to figure out the why. And the why may never happen, the answer to the why. But if you're getting an answer as, we don't really need to do an evaluation on you anymore, we just need to check the machine, to me that would be a clue from Bryn's talk, as maybe we don't have exactly the right healthcare team assembled, because that should not be the answer that you should be given. Great question. Next.
Actually, I have a kid of Tango 2 mutation. He's about 15 years old now, whom we lost his brother on 2012 in Saudi Arabia because of heart rhythm. So he's on device now, which is a pacemaker. And when they installed it on 2012, they told us it's going to be for about 7 years, the battery or so. Since we installed it until now, it has never been triggered, thank God. Is it recommended to put a pacemaker, I mean, in future, or since he's okay, since 2012 until now? Is it recommended to replace the battery for him or no?
I'll give you one. So for that one, I would be phoning a friend, and that friend would be the wonderful Dr. Miyake. Did you like that? Some physicians, you know that expression, stay in your own lane. So I know which lane is my lane. I know which, tricks I'm okay at or I'm good at. So Tango 2, for example, would be a trick where you and your family would absolutely not want to see me because I know nothing about it. That's not my lane. I would be working to get that family, if they contacted us, to the queen of Tango 2, which is here. Okay? So, but the issue in general, to comment on about devices, I don't know your exact situation, but I have a new approach to device therapy, a philosophical approach. And it goes more like this. You may have gotten a device for when you got the device for the best reasons in the deliberations, but I no longer view a device as a forever therapy. I view the device as a for now therapy. And for now, it all still makes sense. But maybe in the future, we learned something and we no longer needed it. maybe in the future, the dark side of the device reared its head, and we've had every complication under the sun from the device, and now the trade hasn't been a good trade. So I don't know your situation of what you do or don't need, but I think the mindset that has to start happening in our field is just because the batteries do doesn't have to mean an immediate reflexive replacement of the device. Usually it's going to, but incrementally, like Nora said, the knee-jerk reaction of course you're going to have a device forever. Oh, really? Maybe today's knowledge is sufficient that the reason we had to implant it 20 years ago, we have a new playbook that we know how to execute, and today's version of that playbook doesn't even have the device listed in it as a necessity. So I think it's healthy. It keeps you on your toes and keeps from getting stale as physicians and scientists. And it forces you, actually. It's easy to say, device forever, turn off the brain, don't search for the reason, just get a defibrillator every time the battery comes due. It's much harder to challenge yourself to say, is the reasons for that defibrillator, the necessity of it, still present? And so I like the for now thinking rather than the forever thinking. Yeah. Oh.
Okay, so I am going to ask a very unconventional question.
Ooh, I love it.
So back
Madison
in 28,
told me you would be. No, she didn't.
she probably did.
No, she didn't. I'm just playing with you.
So I am a
It
survivor.
was Bailey.
Oh Jesus! As long as she got her coffee. I'm a survivor, and I experienced a roller coaster back in 2018, and I have a defibrillator implant. And since then, I've gone on to do amazing things here in the city. And if you need a SADS advocate, it's me, okay? A poster child. I have a request from you, Dr. Ackerman. The people on my Facebook page would love for me to have a selfie with you because I talk about you all the time. And I have something like a following. I'm a chef here in the city, and I have products available at Central Market. HEB stores, and I have a request, a picture with you because I have spent the last 4 years of my life watching you virtually, and I want to share that with my friends and family.
Wow. Unconventional indeed, but it depends on
Please.
the two if they would say permission granted.
You should do it. Yeah.
Please grant me permission. I can do it before you go so I don't make a big old scene, but I know you have 10 minutes left, so I wanted to make sure I
Yes,
asked
so
that.
when you see me heading to the door,
I'm going with you.
You go with me.
Got it.
Okay. We grant her that? That's good. Okay, next question, everybody out there. Embarrassed, flushing me.
Yeah, hi everybody. So, Dr. Ackerman, you know about our child, and we are with wonderful Dr. Miyake for a long time. And we have seen you last year. So my question is actually similar to this gentleman. And, my son, he has a pacemaker for like 9 years now. And he didn't receive any shocks, I guess. And so at this point, first it was diagnosed with CPVT because of some COSQ2. And now I think it's like an unknown issue. But how we gonna decide, or how are you gonna decide if it's an unknown issue? But he is a cardiac arrest survivor as well. How are we gonna make sure that we want to remove the device or we want to keep it?
Yeah.
Since the reason is unknown.
Yeah. In general, and we have more than the 15 minutes. I have 15 minutes. So if you have any questions that you think might be sort of generally applicable, I'm hesitant to try to give a patient-specific reaction. So I'm happy to do any in the 15 minutes. I would just say, in general, for families, if I can't figure out the why to your sudden cardiac arrest, I don't think we have any choice but to maintain the defibrillator protection plan. If we haven't figured out the name or identified a reversible cause or figured out the new name, so for example, you mentioned you're on 5 defibrillators. So a CPVT person who does cardiac arrest as their portal of entry in 2022 doesn't have to get the defibrillator necessarily. That's completely different than what it was 5 years ago, 10 years ago, 2 years ago. So, but if we're stuck in a dilemma of we have essentially inadequately explained or unexplained cardiac arrest, we really must keep a defibrillator strategy present, and to willy-nilly remove it because we've had 8 years where nothing has happened, which is great during the life of that, that's not sufficient proof yet that that episode was a one and done, and therefore we don't need it again. So I think we have to be careful when we don't know the why. Yeah. Jeff, you?
No, yeah, I would agree with that. I think, like Dr. Ackerman is alluding to in some of these, I think it needs continued reassessment, and sometimes things change. Our knowledge base changes very quickly, and just because you had a device placed doesn't mean 10 years down the line that knowledge base and the assessment is the same. And if you don't get that reassessment continually, then I'd advocate for you to springboard that discussion. I have some families where there's 6, 7 kids that have a diagnosis, and the way the oldest was treated and the youngest is very different. The oldest might have an ICD because that's what we were doing back then, and then the youngest doesn't. And it's confusing for the parents to say, my kids have the same thing, how come they're not treated exactly the same? So I do think as knowledge changes, it's continual reassessment of what's needed at the time based on the specific diagnosis, the specific patient, those kinds of things.
Thank you, everybody. Dr. Ackerman, you started talking about reality check on the arrival of gene therapy, but you didn't. I think you were going to say some other things, if you wouldn't mind, before you leave.
Sure, yeah. So gene therapy, as you heard from Dr. Landstrom, is super exciting, but in every new novel therapeutic pursuit, I think super excitement needs to be calibrated with the reality of the pace from a discovery paper to a pre-human animal model that it's working to a first-in-human filing to testing that gene therapy to seeing if it works. So let's say, I'll give a couple examples. So it's already here, as in, has it started? There's a disease, you wouldn't have any reason to know it. It's called Danon. It's a specific genetic form of a heart muscle problem. The first patients in New Zealand have been injected with the gene therapy for that defective protein LAMP2 or that gene LAMP2. So it has begun in our field. The next in line is a gene therapy from a company called Tenaya Therapeutics, who's one of the sponsors of this meeting. That's a specific gene for one of the 2 most common causes of hypertrophic cardiomyopathy, which I don't think anybody has that heart muscle condition in this room. That disease, that therapy first in-person trial will likely start, best guess, 6 to 12 months. Probably pushing it closer to the 12 than the 6, okay? So then there's in the queue, I don't know if any families have ARVC, one of the 2 most common genetic causes of ARVC. That's in the pipeline. That's probably 2 years from commencement. The one that Andrew Landstrom showed you for long QT syndrome that we were advancing, which is being co-developed by Pfizer, is being injected into the long QT rabbits as we speak. So if it works in the rabbits, we file a first-in-human trial, which would start probably 12 to 24 months from now. If it doesn't work in the rabbits, it's game, set, and match, and we start over. Okay, so things get clarified in a hurry with these. Let's say any of these gene therapies work from the first injection into the human. So if you read that the first patient was treated the fastest, and everything's working, the fastest you are going to see gene therapy for that specific disease, for that specific gene therapy, I would bet is minimum 5 years from now. So to get through all of the regulatory hurdles, to convince ourselves in what's called a phase 2 trial that there's a signal of safety, phase 3 trial that it actually works and so forth, and then we do it, this is not, we publish the paper, we're going to tell you it's exciting and it's here, and we start treating our patients with this therapy summer 23. It's going to be summer 2030. Okay? And that's if we have success. Now, the good news is there was never any of what I just said discussed at our last SADS meeting pre-COVID. We didn't even have the chance to give you a potential date of success. We didn't have to tell you that Tenaya Therapeutics is advancing a gene therapy. Pfizer is advancing a gene therapy. Another company, a gene therapy. The space of companies who are now committing serious energy and money to your diseases is like it's never been in my entire career. So that's exciting, because that's going to incubate. What we're doing may not work, but we're going to learn something that will work. And the collective knowledge that's advancing with gene therapy to figure out how do we safely do it so that the person doesn't react in a negative way to the viral vector. What's really been exciting about the companies, so the companies, they're competing mano on their target. What they're not competing on is the safe delivery. They're all sharing best practices on the safety signal. And they're talking to each other and they're saying, what should be the pre-infusion treatment so that the immune system doesn't react? And so that's what's been really kind of neat to see, is in that world, and you know the why. Why would they be cooperating on the safety signal? Because if there's some deaths from safety, the whole gene therapy program of every disease could potentially get killed. So they are beautifully cooperating and partnering with that space. Now, if they own the rights to that gene target, well, then they're the lead dog for that specific gene for that specific disease, but on the safety signal. So hopefully that gives you a sense of maybe a sort of realistic time frame. But gene therapy is not the only thing. There's going to be a first-in-human drug trial for the first new drug for long QT syndrome, starting in LQT3 and LQT2. And that new trial will probably start enrollment. I'm guessing we'll start first patient enrollment summer 2023. There, the track could be a little faster because you can imagine the regulatory hurdles aren't as intense. So if that drug works and it's safe, we could have a first new drug where the indication is long QT syndrome, right? Which we don't have. We don't have a single drug that's an FDA-approved drug for the indication long QT syndrome yet in the history of this disease. That could actually be here confidently summer 25. So that's pretty exciting, I think. Yeah.
I think I overheard you mentioning something about maybe not keeping patients that are asymptomatic on beta blockers for the rest of their lives. Could you touch on that?
Yeah, and I'd love to hear their comments too, because we, I don't surf, but I'm always told that if you surf, you don't want to get caught in the bad part of the wave, because sometimes leading the wave, you can get crushed. So we have to be pretty careful with this strategy that we've started in our program. We call it INT, intentional non-therapy, where we know you own the genetic marker. We know you have disease, whatever, but we've concluded to our satisfaction that we think all we need are the preventative measures. Drugs to avoid, electrolytes to replace, fever to reduce, and we may not need every day of your life therapy. So we started doing that. And we have now in our program over 100 patients where I know I'm not wrestling with the diagnosis like this challenge that Dr. Miyake has with your family. I know what the diagnosis is, but we're saying, I think we don't need treatment. Now, you can imagine the families who are helping blaze that trail. Those are largely families who've said, I think we've traded a low-risk disease for, you've changed my child with this medicine. Again, I don't want the word to leave here saying beta blockers are terrible. They're not. They work great in many people. But the self-declared people where it doesn't, they're the ones willing to say, is there potentially room to navigate non-treatment? So we have many babies who we think the profile is low risk, that we're actually not starting them on their medicine, and we're watching. We are now tempting ourselves with, say, the LQT1 man, who maybe the beta blocker was necessary for his first 15 years of life, but is it going to be necessary for his next 75 years of life when we know the risk window changes? And that's going to be really hard for us to do. Because how do you know that they navigated that first 15 years great because the medicine prevented the events, versus they would have navigated that first 15 years of a higher risk window just fine with no medicine? So I think we're all going to have to be very, very careful on this, because I think none of us want to get snake bit where, the guidelines currently say, if you own a positive genetic test, thou shalt be on medicine. That's the guidelines, basically. There's wiggle room of a class 2, meaning sort of maybe possible for if your profile is super low. And we've taken that as the lead to say, if not now, when? And we have to start that for some families, for the right patient, the right therapy may be no therapy. So we're being careful, and I imagine, I'd be curious, Ron, your thoughts, Christina, Jeff's, as somebody who may not have the volume of patients to say, we'll blaze that trail, versus wanting to watch how that story plays out, because we all know that we're over-treating some patients. So it's an interest. Withdrawing therapy or choosing not to start therapy is actually intensely difficult viscerally for us as caregivers. But I think it is the right thing to do in certain patients. But
I think it becomes increasingly difficult as the patient ages and remains symptom-free, and like any other medical condition.
Thank you. The longer you feel well, the more the disease, the diagnosis is in your rearview mirror. And you have to be reminded, especially in long QT syndrome, that whereas the day-to-day life events don't pose significant risk to you, the kinds of medications that we tend to require as we get older because of age-acquired medical conditions will tip us over the edge in terms of potentially going into a dangerous rhythm. So it's a very complicated process. And I'm not talking about the 15-year-old that Mike is talking about. I'm talking about the 40, 50, and 60-year-old. And so being careful is important, but also not losing sight of the condition that you will always have in terms of the genetic abnormality and the potential that it provides. Whereas the hormonal changes that occur in early life play a major role in risk, and those conditions change as our body changes hormonally. We introduce new cofactors or elements as we get older, and we may go into heart failure and have to be on diuretics, which affect our potassium, or we may have certain infections which require medications that can destabilize our potassium channels. So it's complicated.
Mm-hmm.
For me, I think that you really want from your physician to always look at what's going on with the research, what's new information, and particularly in genetics, to keep up with the genetics. So in other words, even if you're a known disease or a known mutation or an unknown, or you're an unknown cardiac arrest, your physician, or, at least it's my practice, to question it every time you come in. What is the diagnosis? Do you need to absolutely be on this medication? Are we on the right medication? And for me, what I've learned is, honestly, in the field of long QT, and I think this is important, is you see us kind of referring to each other, well, this is kind of your lane, and this is, and yet we all work together, right? We're all sitting here training and trying to share information about certain areas where we might have a little more expertise or a lot more expertise. And I'm pointing out Dr. Ackerman because if you don't know, he is the person in long QT. And, and so if you guys know me, you'll see I have no problem referring you to Dr. Ackerman. Many of you have gone to him. I have no problem with you seeing other experts, but we also learn from them. And so I think it's from what you are putting out in the literature in terms of not only sports, but in who should not be on medications, who might not need it. Here are some guys. I think it's coming from him. And I think when you hear my other families, why am I actually taking you off the medications? It's because I'm listening and I'm paying attention to the literature and what Dr. Ackerman is saying, and then really analyzing, do you really need this? And it's not easy. This process took us, years, right? Several years, to make sure we were doing the right thing and reassessing and reanalyzing and make sure this is the right thing for your family. So actually, Mike, I think I listen and I follow your guidance a lot, in terms of what and these sessions, we learn a ton from each other from this. So I think we take it back to you and we take it back to our clinics, and none of us is an expert in every single thing we're always learning. That's where I think. But it's hard.
Yeah, I don't have a ton to add to that, but it is an incredibly hard decision for us if you want to hear our perspective. It's hard to decide when to start a medicine or when to put in a defibrillator. It is harder for us to decide when to stop a medicine and take one out when we have patients that have been doing well. So your voice matters, because the things for me that influence that are your reasoning, and how people are doing. If someone is having a really hard time with the medicine, that plays an important role in whether or not it's something we could come off of, and things like that. But it's a hard decision for us.
I have one that I hope is simple. So other than attending these seminars, is there like a place or something we could follow? Like maybe the SADS website, or is there a newsletter where we could get the latest news and find out, did the rapid gene therapy work? Or are you guys back in the drawing board? Is there some way that we could figure that out as lay people? And with the medical societies, I'm sure you guys are reading your journals and things like that.
SADS Foundation is your home.
Yep.
Okay.
So if it's not there on www.sads.org, tell the SADS team. If we're missing things that are your need points, that's what we at SADS Foundation need to know, because we want SADS Foundation to be your one-stop resource for your family support needs, your advocacy needs, for keeping you updated. So we don't have enough money at SADS Foundation to fund $100,000 project requests. So we've chosen as an organization that that's not where our giftedness is, or where we can meet families' needs the best. What we are there for is, you need support, it's SADS Foundation. You need advocacy, it should be SADS Foundation. You need to know what's the state of research, or what trials have started, or where is there a place that's offering enrollment. It should be the SADS Foundation, and you should be finding that. If there's specific requests that you have, let Alice and Marcia and Anna back there and Jan back there know.
We also have a weekly, twice a month, e-newsletter that you will all receive in those 2 channels you don't want that. By signing up to it.
Great to see you guys. Thanks for everything. Thank you. Well, Bailey and Madison's mom joined because Namdi is saying I'm on the clock. That's the Toyota guy. who says, "Did you know that if you're 2 minutes late after the assigned time, it's 2 minutes." So anyway, have a wonderful, wonderful rest of your program. Blessings to you. Thank you.
No, thanks. Travel safe. We do have a few more minutes if there's other questions or things. Yes.
All right. So my question's on the beta blocker and flecainide. Is there still new medications coming out, maybe? Like research done for less side effects? And my daughter's on both right now, and she's a cardiac arrest survivor and has had shocks by her defibrillator. So she's doing well with the medicine, but we're noticing mood swings, anxiety, and stuff getting worse.
And is this for CPVT?
Yes, I'm sorry, yes.
Yeah. You want to go?
I would say that right now, those are the two main medications. Those are your mainstays right now. I do think that sometimes we may dose adjust because we really do want to pay attention to those side effects. However, right now, those are the ones we know are the most effective. There are, and you'll see, I'm actually going to talk about some new medications or new drugs that are being investigated right now for CPVT, but they are not yet on the market. They're actually just going through and just starting the clinical trials. So in terms of medication, those are the two. And you heard us talk a little bit about the alternative therapy, which is the sympathectomy.
That's what's next on our stack. She keeps.
Yeah. A sympathectomy is something that's used quite a bit for CPVT. And in scenarios where we have patients that are really intolerant of medicines, that's one of the reasons where we do talk about getting that done, because it has been in people effective in reducing the risk. Again, it doesn't really eliminate the risk and doesn't always mean that you get off medicines altogether, but it does help with reducing that risk. Any other questions?
I've been sitting on this because I'm not exactly sure what my question is. I think I need some guidance on where to go next or what next steps are. When Dr. Ackerman said something about, after you have an event, you get your ICD installed, a lot of providers, it's like, okay, we're done, that's taken care of and there's no more detective work. And I'm new to this. I just had an episode and I experienced VFib in August, got a defibrillator immediately. And we sort of have a why. I have a prolapsed mitral valve, scarring on my papillary muscle. And so they think the scarring is what did it. But my question is, why now? Like, why did it happen on August 22nd? And were there environmental factors that played a role? I had been on 3 different antibiotics for a sinus infection, and so I have questions. I want to start digging, but this involves a lot of different specialties and doctors. And so what do I do to work with my brand new EP? And I haven't even met my cardiologist yet because I transferred from the hospital I was at to Houston. So anyway, any advice or like how to navigate this? That's kind of where I am right now.
Yeah, I think as you heard, I would advocate for you to find that partner champion to centralize advocacy for you. And SADS is very helpful for that. If you wanted to engage after, if you're local, I think it's something we'd love to do. And sometimes it's hard to find the right fit for that. Mm-hmm. But I would advocate to keep searching if you don't feel comfortable. It sounds like maybe your diagnosis is something called mitral annular dysplasia or disjunction.
They just say arrhythmogenic or malignant mitral valve prolapse.
Yes.
Is what they've been.
Yes,
so.
and that's something that's newer and that you see a little bit later in life. And the question you ask is a very hard one that I think almost everyone here would have asked themselves is why did it happen on that date or when? And the reality is sometimes that date's not predictable, especially if you don't have that diagnosis. If we have screened the family and we know a diagnosis before something happens, it's a little bit of a different story. But it's not uncommon that you're very healthy for your childhood. A lot of the diseases we see don't come out till young adulthood, and that's when it presents. And so I don't have a great answer for why it happened on a specific date or things like that. For mitral annular disjunction and mitral valve prolapse, there's a lot of looking into and work that's going on. And so certain medicines, including flecainide, which has been used with that quite a bit, as well as some places where they've done other things in terms of looking at the papillary muscle. But I would advocate, if you don't feel comfortable, that you're getting that centralized advocacy for you to keep searching.
Yeah.
As a peer, I would like to help you with that.
I got a big mouth. It's big. As a peer, I would love to help you with that because I am a patient at Vital Heart and Vein. They may have a place close to here, but I'm in Humboldt, Texas. And the cardiologists are very into SADS and they're very knowledgeable, and I would consider them experts. That's a good place that you could start. I'm not a doctor. But they have been extremely pivotal in helping people like us because I experienced my first event when I was 30 years old as well. So you could start there.
And I think that it's good that you at least have some. At least they've given you some information. I think I'd probably be a little more specific because there is mitral valve prolapse, the malignant form. There's mitral annular disjunction. And you also want to make sure, is that definitively your diagnosis? Could it be something else? And it is common, it is much more common in females, this MAD, and particularly young females. I don't know your age, but in general, starting in their young 20s, much more. It's just we know that that's a common age, but at the same time, when you talk to your physician, I think you get that. Hopefully you get that feeling, is my physician listening to me? Are they, when I bring up, was it antibiotics or was it this, are they listening and saying, okay, I'm hearing you? Because personally, I think that we learn a lot. I learn the most from you guys. And maybe there was something about that antibiotics, but no one knows. And I'm not saying that they're always going to pay attention because sometimes there isn't a connection and we know that. But you want to make that connection with your physician and make sure they're hearing you and you feel comfortable with your diagnosis. I don't think you should ever leave and live for years without knowing your diagnosis. And I know there are people in here who didn't find their diagnosis for much longer, and maybe because they didn't have that, their physician wasn't always asking, and that's what you want. So if that's not, and that's what I think he was saying, is making sure you have that. SADS is definitely the right place. But you have, what's wonderful about this is you're meeting others that are going through the same thing. And hopefully if you continue to connect with people like that, you can find different avenues until you find that right. Don't feel like you have to stay at one spot. Look around, use resources, and find the right person for you. And it might be where you are. It's just,
Other questions? Okay. I thought we were going to spend half the time talking about sports and participation, which is where it usually heads, but it didn't come up.
Since you want to go there. My oldest daughter is 15, and she actually came here. She sees Dr. Valdez.
Okay.
And he's incredible. It's me. I'm the problem as far as her athletics. It's the parent. She wants to play basketball. She wants to run track. She wants to play volleyball. She does all of these things. But she's also very intelligent. She's in tune with her body. It's me. I want to be able to tell her, yes, go do those things. They're amazing, and go run your heart out, but not literally. And she's on treatment medication daily, almost the same dosage that I take as well. As a parent, with your experience as a pediatrician, what are some things that you would be able to offer other than support groups? Maybe, I don't know. I don't know what I'm asking, but what have you seen in other parents that are like me and maybe some other people in the room who freak out and make sure that there's an AD on the court and things like that?
Yeah.
Because I also have long QT and that triggers my anxiety. So there's that.
Yes, no, it's a great question. And I think what can we offer, what I would say is probably data, because what we all hate is the ambiguity around it. And the reality is that we're never going to be able to tell people, even without any of these diagnoses, that your risk of doing something is 0. But what a 0.1 or 0.2 or 1% risk means to you may be different than what it means to somebody else, maybe different than what it means to your daughter. But you can't even get to that point if you don't have the data. And so I think one thing we could provide is to go over that data with you. I would say that the model for this is now, and you've heard the term shared decision making. It's new. It's not long ago that it was you have a diagnosis, and it was easy for us back then, to be honest. You have a diagnosis, you can't do X, Y, Z. But really, for long QT and a lot of these other diagnoses, it's about shared decision making. And that word shared is important. And it's something that I still haven't taught my youngest daughter. I don't think she understands what shared means. But shared means that it's bidirectional. And so with a child, sometimes it's 3 people. The child, the patient, the parent, and the physician. And if you have one party that's not involved, then that's a problem. And if you have a physician that says this is how we have to do it and doesn't listen to your side of it, that's a problem. At the same time, I think if we have a patient or a family that comes in and doesn't want to hear anything and says this is what I want to do, I think it's also a problem. So I think it's a long, important discussion and a shared decision that you make. What I would say is that most of these diseases now we've shown that the risk of having an event during sports participation is low. If you're followed, you're treated, and you're managed and having these discussions. Not 0, but low. And there's some diagnoses that are a little bit different, so it depends a little bit on the diagnosis. But I think having that shared decision making to do that is important. Your perspective is important, and I think your daughter's perspective is important. In the era where we restricted everybody, one thing we saw very common is that the child or the patient got very depressed. Their life was shattered. It was very important. That's an important part of the balance, because when you hear the statistics and the data and you say, well, maybe there's 1%, and you see the impact that the restriction had on your child, that could shift it. And I've been on the end where I've restricted too many patients, and I see how they've changed. And that's what's really resulted in that model, is that you have to factor all these things to make sure that people are still able to engage life, which is the whole purpose of SADS. Whole purpose of all this is that we want people to continue to engage life and the things they want to do.
I was just, do you want to?
I'm over here. Hi. I was just wondering, having gone through this for the majority of my life, and then when I had to be 12 years old and I was put on this beta blockers, it changed my life. Like I could actually be active and do all this other kind of stuff, but it made me feel, I didn't know it would make me feel slower, because of just the beta blocker, which I was fine with as long as I could play football and all that kind of stuff. But from an emotional, like you just meant from an emotional state of mind for the child, how do you go about explaining to him that things it'll change or slow down? You might feel this, or is that obviously that's very tough for you.
Yeah, I think my approach to, particularly, it's a little bit different if you're a child. I do think it's important that they're involved and understand something, to not hide the diagnosis from them, but you might want to talk to them differently. But once they become a teenager and the 12-year-olds, I really think they should know what's going on. And so I'm very open, and I tell my patients, we need to have a very open relationship here. You need to tell me what you're feeling. We need to be able to talk. And so I think that hopefully you're kind of a survivor. It's been a long time, but hopefully us physicians now are learning from you and talking to you and telling you, here's your diagnosis. Here are your medications. And I make my patients tell me their medications, their doses. Be responsible for your own health, and here's how you might feel. And if you are, then tell me so we can work through that. So I do think that's an important part. Work with your physician in terms of your questions. Absolutely, it's important to recognize that these diseases, they play a toll on your psychological health too. And so it's really important that you also consider outside counseling or someone else to support you and your child to go through this. And be open with your physician. Sometimes we don't always do this, but we probably should. Be willing to maybe step out and let your teenager talk to their physician, tell them openly what they're feeling, and encourage them to do that. And then also encourage them if they, I encourage everybody, regardless, to have some counseling, because this is difficult. And there are some counselors, this is really hard to find, but Sam Sears was here yesterday, and he focuses on cardiac diseases, devices in children. And actually he trained the psychologist here who know more about these diseases and the manifestations and repercussions that it can have. So I think, working with your physicians and being cognizant of what it can, what it can mean for your child, and at least you recognize that. I think that's really important.
Mm-hmm. And I would just say, don't let us tell you that we're only caring about this.
Yeah.
This is what we trained in for years. But if your physician says, I don't care about anything else other than your heart, then that's not right. Because we know that, people are much more than just their heart. That's what we're focused on. But it's coming much more into focus that everything interplays. We need to pay attention to things like that you brought up.
One thing that's given me peace of this, is this louder than it was earlier? Okay. Given us more peace of mind as parents. Our daughter is 9 years old and she has CPVT. She's diagnosed right before she was 6 years old. So it's been almost 4 years and we've been with Dr. Miyake the entire time. So it's been a journey, and she has a loop recorder, which for me was a decision we made with Dr. Miyake and with ourselves and with her to make us feel better about allowing her to do more things, making sure she's medically managed correctly. And then that was the other piece of the puzzle and I explained to her that this is something that will help us hopefully enable you to continue to be an active child. And she understands why she has it. And she understands doing a transmission that gives information to Houston that, make sure that things are okay. And as long as they are, we can continue to lead a more active life. But that's just something from our experience that I wanted to share because it helps me feel a little bit better about giving her that blessing to participate in things like that.
I'd just like to say a P.S. to what I said before. But I am so thrilled to be here and hear of all the advancements that have been made to what I once knew was a helpless situation. I was in the wilderness back in 1973 when my child, my 3-year-old, couldn't run or ride a bike or anything without quote, quote, fainting. And I had nobody to turn to. Nobody. We had the best pediatricians, neurologists, neighbors, everybody who wanted to pitch in what they thought. And that went on from the time he was 3 years old till 10 years old, and he passed out 35 times. Riding a bike, jumping on the bed, dancing in a group. And so when we finally heard by no, not a mistake. A quirk from heaven, really. I was at a luncheon, and some ladies and I were talking, and we got to kids, and I told them about this child of mine fainting, and this one lady said, "Has anybody ever mentioned to you QT?" Now that's how it saved his life, because I had a tour business at the time. She wrote me a thank you note, and she said, "If you've never heard of this QT, go see this doctor." And my pediatricians, neurologists, and everything, the best in New Orleans, said, "He's over the hill. I don't want to pay any attention." And so we did, and the best he did was tell us he was on his way to Rome to study this prolonged QT thing. He had never heard much about it either. And when he came back, he told us to be there with a chest x-ray and a new cardiogram. And he walked into the office that day, and he pitched a brochure on the desk towards my husband, and he says, "This is what he has. It's fatal." And that's it. I said, "Is there anything, nothing they could do?" And they said, "Oh yeah, cut something in his neck that would paralyze his face and close his eye." And so I was frozen in the office, and when we left, I said to my husband, a very stable, good guy, a lawyer, and I said, "Well, what are we going to do?" He says, "We're going to lunch." He's nuts. But he really wasn't nuts, because all the neurologists and pediatrician had said if he went 18 months without fainting, it was probably idiopathic. Well, he bombed out 2 months later, and then I gathered all of his records from all of the doctors, and we went to the LSU School of Medicine. That doctor concurred with the one who was nuts, as supposedly to seek. But, and this is a really soap opera, because he discovers what the other doctor said was true, but nobody ever heard of this QT thing. And so we go the whole summer with nothing. But, nobody said anything. And so I called the pediatrician in late August, and she said, "Did you ever get the prescription? How is Matt doing on the prescription from Dr. So-and-so?" I said, "I don't have a prescription." And she said, "What?" And I said, "I don't have a prescription." Very first woman doctor in New Orleans. She banged the phone down. She said, "I'll call you back." Then she told me to race to this cardiologist, pediatric, and let me tell you, he didn't know about it either, because I tried to explain to him how all those years of his passing out, we tried to keep a good sense, and saying it was a tonic. It was a tonic, and it made you feel better and all. And he bought it. But this time, it was when he said it was fatal, we had to do something big time. So that pediatric cardiologist treated him till he was in college. And he certainly learned about the QT. So after this long dissertation, I just want you to know how lucky you are to even ever heard of that, and all of the progress that has been made for you to be able to breathe a calm breath and not have to be in a quiet panic for the rest of your life. So thank you, doctors, and thank all of you for letting me rattle on. Okay, that's it.
Thank you. We love those sessions. Maybe we'll give everyone just a few minutes to stretch legs. Push forward with the agenda. Yeah. Oh, yeah.